Good afternoon, everyone. On behalf of the Hershey's Mill Sports Committee, we are here introducing Dr. Gabe Kresge, who is a doctor of physical therapy and the director of the Westchester Kinetic Physical Therapy Clinic over there in the ACAC building. Dr. Kresge.
Awesome. Thank you, Sherry. How's it going, everybody? Thanks for coming today. I'm sorry that we didn't get to do this in person. We decided, talking with Sherry and the committee, that it was probably just a better idea this week to put this one on Zoom. And I'm really excited about the attendance. And honestly, this is one of my favorite seminars to give. This is the first one I created about 5 or 6 years ago. And I usually get a lot of great info and great feedback from this one in particular. So anybody that wants to either learn about the shoulder or has had shoulder issues before, I think this is going to be a great seminar for you guys. So I'm going to share my screen here and I'm going to pull my PowerPoint up and we'll get started. Okay. So guys, the title of this seminar is Bulletproof Your Shoulders, and the whole purpose of this is to help you to understand what creates a strong, resilient shoulder. And it really helps you if you either have shoulder pain or shoulder dysfunction, or if you've had it before, how to stop it and how to make sure it does not happen again, or at least helps improve your quality of life and the quality of shoulder function that you have. So here, I used to have a video of Hafthor here pressing both these girls, and I lost it. So I just put this video up. This is the world's strongest man, Hafthor Bjornsson, pressing these two women on top of this barbell. If you want shoulders like him, you came to the right place. So if you guys, this is your first time being introduced to me, I just wanted to give you a little background. Again, my name is Gabe Kresge. I'm a physical therapist. I graduated from the George Washington University physical therapy program in 2016. And I've been the director of kinetic physical therapy in Westchester for the past 3 years now. I have had shoulder pain before. I've had shoulder dysfunction before, so I know firsthand how debilitating and uncomfortable it can be and how much it impacts your daily life. So the purpose of this seminar is a few different things. I want you guys to learn the anatomy of the shoulder, just some general anatomy stuff you've heard before, including local muscles and the role that those muscles have in movement. I want you to understand the basic kinematics of the joint, or how the joint is supposed to move in order for healthy shoulder motion to occur. I want you guys to recognize common movement faults and consequences of repeated poor movement patterns. And I want you to apply the principles that you learned today to help address your shoulder motion, or seek help if that's something that you need. So we're going to start with some basic anatomy so you guys have an understanding of what I'm talking about through the rest of this presentation. Your shoulder is a pretty complex joint. It's actually 4 different joints make up your shoulder. The one that you commonly think of that you know is the glenohumeral joint, which is the ball and socket joint, right? With the ball sitting in the socket right here. You also have your sternoclavicular joint, which is where your clavicle or your collarbone meets your sternum. You have your acromioclavicular joint, or AC joint, where the end of that collarbone meets your shoulder blade. And then we have this 4th joint, which is more of a pseudo joint, which is your shoulder blade on your rib cage. So that is not really a true joint, but there is an articulation there where this shoulder blade has to be able to sit and move on your rib cage. And so we term that the scapulothoracic joint. So all 4 of these joints need to be functioning properly for you to have full and normal range of motion. Just as a quick overview of what happens when you just reach overhead. It sounds like it's something easy. Hey, when I just do this, my shoulder works and I reach overhead. A lot of things are happening when you just do that.
Oh my.
For example, your arm bone is rolling in your socket like this, right? It has to roll and it has to slide. Your shoulder blade is rotating up like this. Your acromioclavicular joint is dropping down, and your clavicle is rolling in the sternum. All those things are happening every time you move, and we take it for granted. If one of those things is not occurring properly, that's going to affect what's happening at the shoulder joint itself.
Oh boy, oh boy.
So let's talk about movements. Again, all four of these joints need to move efficiently for shoulder motion to occur. So again, your scapula has to move, your humerus rolls up, your AC joint moves upward on your clavicle, your scapulothoracic joint rotates upward, and you also need adequate mobility in the middle of your back, in your spine. And we often address that because what happens is your shoulder blades rest on your thorax. So if you get into this more of a forward shoulder posture, or this like kind of hunched back posture, your shoulder blades are resting on that spine. So if your spine is in that position, what we call kyphosis, your shoulder blades are resting at a tilted angle. That affects how they move as well. So oftentimes when we see people with shoulder dysfunction, we have to address their thoracic spine movement as well. So I'm going to pull up this video here of what should be happening as you move your shoulder. I want you guys to see, this is a great illustration of what happens every time you move.
If you want to eat healthy and feel your best,
After we skip
you
this
gotta
ad,
try Kresge. Kresge is the world's healthiest.
So what they did here is they used a computer model to illustrate all the things I just talked about. So we can see when you're going in from full extension to full shoulder flexion. And we can see, obviously, the ball is rolling in the socket here. There's things happening at that arm joint. But look at all the things that are happening aside from that. Your shoulder blade's moving. Your clavicle is rolling on your sternum here. This joint, where your collarbone meets your scapula, that's moving up and down. All these things are happening whenever you move. So in order to assess and to address shoulder dysfunction, we don't just look at the ball and socket joint. We're looking at everything, or at least physical therapists are looking at everything, because that's what we do. We assess movement. So there's no one better qualified to assess the movement of your shoulder than a PT, because we actually have to know and figure out what's going on at every one of these joints. So we talked a little bit about the skeletal anatomy. We're going to move on to the musculature, and these are probably some terms that most people have heard before. So you have what we term a rotator cuff, which is a group of muscles that help do a few different things in your shoulder. Your rotator cuff is made of 4 muscles: your supraspinatus, infraspinatus, subscapularis, and teres minor. The rotator cuff's job, its primary job, is to hold that ball centered in the socket. Your socket itself is pretty shallow in your shoulder. It's not like your hip socket, although they are the same ball and socket joint. Your hip socket is deep, so the ball sits deep inside of that socket. It's pretty stable inherently. Your shoulder joint is much more shallow, so that socket is not as deep as your hip socket, and it needs more stability that it gets from local muscles. So all 4 of these rotator cuff muscles originate on your shoulder blade. They start on your shoulder blade, and the belly of the muscle is on the shoulder blade. They then wrap around on different points of that ball, and they keep that centered in the socket, provide a lot of stability for the joint. These muscles are small. They're not necessarily prime movers, in that they're not doing all the work when you lift your arm or lift a weight. That's the role of your deltoid and some of your other big muscles around your shoulder. These guys are primarily for stability, but they do assist in motion as well. So that is the primary job of all 4 of those rotator cuff muscles working in unison.
Rotator cuff muscles.
You also have a lot of other local muscles that we would term scapulothoracic muscles, which means that they originate on the thorax and they move your shoulder blade. There's a ton of different muscles that do this. And remember, your shoulder blade moving is a big part of why you can do things like reach up, reach behind your back. Muscles that do that are your upper trap, your levator scap, muscles in your neck and shoulder, your rhomboids, your tricep, your serratus, your latissimus dorsi, your pecs. All of those muscles also play a role in moving that shoulder, and they provide, or they are important in getting that shoulder blade to move efficiently, whether it's reaching up, reaching behind your back. All those muscles play a role as well. So you can already see only after a few slides, there's a lot of different things going on here at your shoulder. It's a very complex joint, a lot of different moving parts in order for it to work like we want it to. Getting back to the kinematics here, when you reach up, let's just say you're reaching overhead, the motion that comes from the shoulder, the ball in the socket, you have about 120 degrees that happen from just the ball in the socket, right? You should have 180 degrees of shoulder motion. 120 of it comes from the ball in the socket itself. That other 60, which is very important, that can make all the difference, that comes from your shoulder blade moving. So that shoulder blade upwardly rotating, just for example, when we're reaching overhead, is responsible for like a third of the movement of your shoulder. Let's go back again to assessing your spine, right? When someone comes in, they're like, man, my shoulder is really bugging me. It hurts when I reach overhead, right? If we're just looking at their shoulder, we're not getting the whole story. What often has to happen is we have to assess movement in those joints around it, including your back. Again, if that shoulder blade is resting on your back and it's in a tilted position, or it's already abducted or forward or around your body, it's not going to be moving efficiently. It's not going to have this normal 60 degrees that we want. That may not be the shoulder's fault. That just may be, my back is really stiff and I have trouble extending all the way. All those things play a role in shoulder motion. Going back to the anatomy now, we know that the shoulder blade needs to upwardly rotate. And there's a few things that can affect that, being the spine, it resting on the spine, but also the strength of the muscles that help move it. So what we term a force couple is muscles that work together, right? That work in unison to accomplish the same goal. So a force couple, or a common force couple that is really messed up in most people that come in with shoulder injury, is they have an imbalance or weakness in either your upper trap, your lower trap, or your serratus. Those muscles, all three of those, work in unison to bring that shoulder blade forward. Most people don't have a problem with the upper trap. This is this muscle in your neck that when you're stressed out, you're like, oh God, this thing hurts. People usually don't have weakness or necessarily problems with that muscle. If anything, that muscle is often doing way too much, right? This is the kind of thing where you see someone trying to reach overhead and their shoulder hurts, and it looks like this, like they're hiking their shoulder up to their ear, right? That is your upper trap. That's that muscle trying its hardest to help get that shoulder up. However, it's these other guys that are usually the problem. That upper trap is usually doing a lot of work because these other guys aren't. And those other guys are your lower trap and your serratus. Your serratus, specifically, just to speak on that for a second, is this muscle here, which goes from your rib cage to underneath of your shoulder blade. It keeps your shoulder blade against your thorax and is a prime mover in upward rotation. That is a common muscle that we end up usually training when someone comes in with shoulder pain or shoulder dysfunction, and we find weakness there. Having adequate strength in a lot of these scapulothoracic muscles is key in order to be able to have adequate movement of the shoulder. So we just talked about a lot of anatomy there. Just want to summarize the main things I want you guys to take away from that. All four shoulder joints have to be able to move freely. And we're talking about this in terms of why dysfunction develops in people with shoulder pain. One, all four of those shoulder joints must move freely. They have to be able to move efficiently for that to happen. Your rotator cuff has to be able to hold the humerus steady in the glenoid during movement. Your scapula must be able to move freely on your thorax. And then finally, you have to have sufficient strength and control of the surrounding shoulder girdle muscles in order to move effectively. So that is a basic understanding of the anatomy and the kinematics of your shoulder. I'll stop there for a second. Does anybody have any questions specifically about what we talked about, the movement, what these muscles do, anything like that? Great. All right, I did a good job. You guys all understand everything. Sweet. So
Gabe, hold on a second. I have to ask everyone to unmute so that if you have a question, please unmute yourself and go ahead and ask. I think we have a question coming from someone who's on by phone, but I didn't hear anything. If you want to try that again. Jerry, do you have a question? I see you've unmuted yourself.
Only because you said do it.
Oh, well, just
Oh,
unmute yourself
I-
if you have a question.
Well, I was just able to get sound. I'm just now getting into the show.
Enjoying his
Oh.
peanut butter and jelly.
got it. Okay.
Oh,
Hey,
Sure.
hey, Sherry, this is Dave. Will we be able to get a copy of the PowerPoint presentation?
Dave, I'm recording it, and so that will be available. I
Great,
can
thank you.
send it to you.
Thank you.
All right, great. All right, guys. Well,
The person on the phone tried to talk again. Do you have a question?
no,
Okay, all right. Thanks so much.
okay. So moving on, guys. So how does dysfunction, right? Like how does shoulder pain begin? How does movement dysfunction begin? Forgetting the fact that, let's say we have like an acute injury. Let's forget about like I fell and broke my arm, right? How does dysfunction begin? Most times when people have an insidious onset of shoulder pain or dysfunction, it happens for a number of reasons, and it usually connects back to your body adapting to positions or to things that it does. So your body is a miracle of nature. It's one of the most adaptable things and resilient things on earth. That's why some people can hold their breath for 10 minutes. It's why people can lift 1,000 pounds off the ground. It happens because your body can adapt to the stresses that are placed upon it. It's incredible at doing that. And so because your body will adapt to whatever stress you placed on it, your tissues, right, your muscles, your ligaments, your joint tissue, they're going to adapt to positions they're in and demands that are placed upon them for long periods of time. So let's just take an example, one that usually affects our older clients as they're coming in. And let's say they just have more of a forward shoulder, forward head posture, right? Their upper back starts to round, their head is more forward, their shoulders are more forward around their body. This doesn't happen overnight. This happens over years and months, right? And that is usually because that is the position that their body, their head is in more of the time, right? Going back to posture and what we talk about when I say you have like bad posture, is that I would argue that there's not really a bad posture. You should be able to move in and out of these postures. You should be able to bring your head forward and round your shoulders to do all that. That's not necessarily bad. What we want to avoid is fixed postures, or postures that become fixed and are not flexible, meaning you cannot move out of them. Those are the postures that end up causing dysfunction, when you cannot move out of it. So sustained postures for long periods of time without being able to move out of them is really the culprit of a lot of these problems. So a few examples here is someone that works at a desk all day, right? If they're always sitting down, they're always working in front of their body at a computer or at a workshop table, right? They're going to be more prone to have that more forward shoulder posture because they're always doing things in front of their body where their shoulders are around their body. Same thing goes for a mechanic. A mechanic is in a position where he might be working underneath a car, and he might be in a lot of what we call cervical extension a lot of the time. So he's always looking up because he's working above his head. Same thing with the person sitting on the computer here in her lap, right? None of those postures are necessarily bad, but when you're in them routinely all the time and we don't move out of them, this is when dysfunction happens. And I love this this photo here. This is always a good illustration of how our bodies change and develop over time. It doesn't happen overnight. It takes a while. So Common faults that we see when someone gets stuck in a fixed posture, let's stick with the forward head posture, right, is something we call upper crossed syndrome. This is an adaptation that happens when your head is usually forward for most of the time, and some of these more flexible postures become fixed. So upper cross syndrome is termed because of the imbalance between length and shortening of muscles on both sides of your neck. For example, when someone has this forward head posture or they have upper crossed syndrome, they will present with a tight upper trap and levator scap. These muscles in their shoulders are shortened and they're tight. They'll present with weak deep neck flexors, which is the muscles in the front of their neck. They'll present with weak middle trap, lower trap, and serratus, and they'll usually present with tighter pectoral muscles and lats. There's an imbalance and a cross between tightness and length and strength and weakness. As an aside, your muscles are contractile. They lengthen and they contract, and that's what allows you to move. Having a muscle that is perpetually in a shorter, more contracted position, such as a tight muscle, or a muscle that is weak and in a lengthened, extended position, those positions, both short and long, those are both going to result in weakness of that muscle. A muscle will not be as strong if it doesn't have that adequate balance of length and tension. If it's too short or if it's too long, it's not going to be as strong as it should be, and that can lead to dysfunction. Again, guys, your body will adapt to the task required of it. I put this picture in because this is a picture of some children with polio. And you can see that even though this boy has polio and he's stuck in this position with this kyphotic spine and these hyperextended knees, he is still able to walk. I mean, he's learned to walk on his hands and all fours. So even though he had polio, he's figured out a way to walk. His body adapted to the stress that was placed upon it. And this happens on a macro level with diseases like polio, and it happens on a micro level with the movement in one direction of your shoulder. So putting all these things together, we know what should be happening at the shoulder. We know how these pathologies develop. Common things that we see and that people come in with when they have shoulder pain, whether it be chronic or new, is they might have things like impingement, something called bursitis. They could have a rotator cuff strain or tear, and we'll talk about the difference between those. And they could have something called shoulder instability. These are probably the four most common dysfunctions that we see in physical therapy when someone comes in with shoulder pain. And we're going to go through all of these, and we're going to see if you guys can equate anything that you've ever dealt with to maybe one of these pathologies. So non-traumatic shoulder pathologies, which means these didn't happen with an acute injury, right? Shoulder impingement and bursitis are perfect examples of these. Shoulder impingement usually occurs when you end up pinching a rotator cuff muscle, usually your supraspinatus, between your humerus and the top of your collarbone. This repetitive impingement of that muscle leads to pain and that muscle becoming inflamed. That same thing can happen to the bursa. The bursa is just a fluid-filled sac, which is in that same space. The bursa itself can become inflamed, and both of these essentially lead to pain. We talked about what should happen at the shoulder and what movement is supposed to happen. Impingement can occur if, for example, you don't have adequate shoulder or scapular upward rotation. Let's say your shoulder blade isn't moving the way it should. If your shoulder blade can't fully upwardly rotate and you're hanging lights for Christmas, you're doing that for hours, and we're pinching that rotator cuff muscle because your shoulder blade doesn't move, that's a perfect example of something that could result in pain. The same thing can happen if you have a pathology known as a frozen shoulder. Frozen shoulder itself is a weird condition that we still really don't know why it happens. It's associated more with individuals who have diabetes. But in frozen shoulder syndrome, not the rotator cuff muscle, but the capsule itself, which is the tissue that surrounds where the ball is in the socket. That tissue becomes very stiff and rigid, and it prevents that adequate roll and slide that normally occurs. That can result in pain and stiffness, but that can also create shoulder impingement, which can result in this pain. So both of these are perfect examples of non-traumatic shoulder injuries that happen because of a movement dysfunction. The joints aren't moving the way they should. And in order to alleviate that, in order to fix that, we have to improve that joint mobility. That's usually the first thing we're doing. Next, we're going to talk about rotator cuff tears or strains. This is something that a lot of people deal with. It happens as we age. But before we get into that specifically, I want to talk about the difference between a strain and a tear. The difference is that there really isn't a big difference. They're pretty much different terms for the same type of thing. There's just different grades of it. So a strain, there's different grades of strains. A grade 1 strain would essentially be you disrupt the normal length tension relationship in a muscle. That creates some tiny micro tearing at the muscle, and that results in some pain. The muscle heals over with scar tissue, like how our body heals, on a very small level, and then you're out of pain, you move, you keep doing your thing. A grade 2 strain would be a further disruption. So a little bit of a greater strain. This sometimes results in this bruising, right? That can happen. And you have a greater disruption of those muscle fibers. Those, again, they heal the same way anything else does. Usually a little bit more care, and then they get better. A grade 3 strain is what we would more commonly call a full thickness tear. So a full thickness tear doesn't mean that the muscle is torn in half. It doesn't have to be completely torn. That's pretty rare, but it can happen. A full thickness tear just means that the tear goes through the full length of the muscle belly, which means you can have for example, you can have a piece of paper, you can poke a hole through it, and you have a full thickness tear through that paper, right? It goes through the full paper, but the paper is still intact, right? It's not like you rip the paper in half. The same thing can happen to your muscles. So that grade 3 strain is often what we call a tear. Those are the ones that often require surgery if conservative treatment fails. The grade 3 full thickness tears are ones that sometimes, because enough of the muscle is disrupted, you surgically need to suture that muscle down and repair that tear in order to get full function back. Sometimes that is necessary, for sure. The question people always ask when it comes to rotator cuff tears is, do you actually need surgery or not? And what we found over the past few decades with research is that rotator cuff tears are, in general, becoming a pretty normal part of aging. And what that means is, in studies, they will look at and take MRIs and imaging of people that have shoulder pain and people that don't have shoulder pain. And what they'll find is people that don't have shoulder pain will still present with rotator cuff tears. They might not be full thickness tears, but they're going to present with tears in the rotator cuff that are asymptomatic. They have no pain, right? So what we take from that research is, just because you have a rotator cuff tear does not mean that's the source of your dysfunction all the time. So a lot of times people will go get an MRI, they'll have shoulder pain, they'll see that they have a rotator cuff tear, but they won't do surgery. And that's a pretty common occurrence, because most tears can be treated conservatively without surgical intervention, and the outcomes are still the same. That's what the summary of this study here is talking about. In this study, which was conducted in Japan, consists of a pretty large amount of people, over 683 people, male and female. They were averaged about 57 years old. Rotator cuff tears were present in 20% of the population, with 36% of the subjects having symptoms of rotator cuff tears and 16% without any symptoms of rotator cuff tears. So rotator cuff tears in the general population are usually associated with patients who are older, if they've been engaged in heavy labor, or if they have a history of shoulder trauma. But again, what we find is that they don't always require surgical intervention. Oftentimes that's not indicated, and they need to be treated conservatively, which is where physical therapists come into the picture. In this research article from the Bone and Joint Journal, they conducted research in Finland around treatment of 173 patients, right? Again, age 55 in the middle, with supraspinatus tears. The patients were assigned to 3 different groups. Okay, so the first group in this study received PT. The second received an acromioplasty. which is essentially them shaving down a piece of your acromion to create more room in your shoulder joint. The second group received an acromioplasty and physical therapy, and the third group received a rotator cuff repair, acromioplasty, and PT. So again, we have 3 different groups: PT alone, acromioplasty and PT, rotator cuff tear repair, acromioplasty, and PT. The physical therapy consisted of home exercises, right, that they just gave them, GH motion or glenohumeral joint motion and active scapular retractions for the first 6 weeks. And then with an increase during the next 6 weeks after that, followed by strength and resistance training for up to 6 months. Essentially 10 sessions were conducted, which is not even a lot in general for PT. Following all this, when the patients were assessed using a constant score, which is basically an outcome measure at 3, 6, and 12 months, there were substantial similarities in the rates of improvement in all of these groups. So essentially what they're saying here with this study, with this large group of people, is that although some received just PT, some received an acromioplasty, and some received a rotator cuff tear, the outcomes were pretty similar and they weren't significant in one group over the other, which means that you can treat these rotator cuff repairs and get the same outcome without having to undergo surgery. Hang on, guys, let me just move this to the side. Okay. So we talked about shoulder impingement. We talked about rotator cuff tears. Now we're going to talk about shoulder instability. This is usually a more rare condition. I shouldn't say rare. It's just less common. Most people will have problems with the mobility of a joint. Instability is usually you have too much motion in your joint, or you don't have enough strength to control the joint. So if we look at this girl stretching here, that's an amount of shoulder extension that most people don't have. She has a ton of motion at that shoulder. The question is, can she control that motion? Because if she can't, she's going to develop pain because of a different reason. So instability refers to excessive movement of the humerus on the glenoid, right? So the ball in the socket, there's too much movement going on in here. This usually results in laxity in the joint capsule. It can result in a sensation of clicking, popping, subluxation, which is the shoulder joint actually, the ball coming out of the shoulder socket and back in, or dislocation, which means the shoulder joint comes out of the socket, the ball comes out of the socket and does not go back in. Chronic laxity and subluxation often results in what we would term a labral tear, which is essentially a tear of the tissue that separates the ball and the socket. It's tissue that's inside of the joint here. And when you have instability at a joint, or there's a lot of movement happening in the ball and socket, it's much easier to get a labral tear. So in summary of these pathologies that we just talked about, common non-traumatic shoulder injuries usually include impingement, bursitis, rotator cuff tears. They can be atraumatic or traumatic, or chronic instability. These pathologies are often the result of poor movement patterns and or inadequate strength of your rotator cuff and surrounding shoulder girdle muscles. Conservative treatment for these pathologies is recommended to alleviate pain and to restore function before surgical intervention is recommended. And conservative treatment should be utilized before electing surgical intervention. Because of the research we talked about, the outcomes are often the same. So it's more cost effective with the same outcome. Now, this does not mean that every shoulder injury or rotator cuff tear can be treated conservatively, but that is usually the route that most medical practitioners will go. They will elect for a conservative treatment first before you go for a surgical intervention. So, does anybody have any questions about those pathologies?
I have a question on the tear discussion you had on the severity of the tear.
Yes.
How do you diagnose how severe? Do you have to do an X-ray? Is it an MRI, or can you just do a physical examination?
So the answer is you could do either. When someone comes in with shoulder pain, let's say these are things that orthopedic doctors used to do way back when. They wouldn't just go right to imaging. Now PTs are primarily the people that are doing this, but we can give you various orthopedic tests. So if you come in and you have shoulder pain and you say, I hurt my shoulder, right? I don't know what I was doing. I was lifting something and I'm not sure what's going on. What I can do is give you 4 to 5 different orthopedic tests that are testing for rotator cuff tears. One in isolation is usually not very helpful. So if you are positive with one test, I still can't be sure that you have a rotator cuff tear, even if that test is positive. For example, a common injury or a common test that'll be positive if you have torn a specific muscle in your rotator cuff called your supraspinatus is an empty can test. An empty can test is essentially you holding your arm out to the side, okay, pretending like you're holding a can. This alone may just hurt. And then I say, hey, if you're holding a can, pretend like you're going to dump that can out, like you doing this motion, okay? This motion here, you flipping that over in that position, immediately requires you to turn on that supraspinatus muscle, and it puts a lot of stress on that muscle. If you have pain doing this, or it's hard for you to even do that, and that reproduces your pain, then I would say, okay, that's a positive test for your supraspinatus, right? But I'm probably going to give you 4 or 5 more, and I'm going to use the data from that cluster to say, hey, you had 3 of these 4 positive. I'm pretty sure you have a rotator cuff tear. Let's start treating this. And that's often what even some not just PTs, but some orthopedic doctors will do. That's one way to determine, okay, I have a tear. Although I don't know the extent of it, I can guess that if you can actually move your shoulder and go through it, it's probably going to be able to be treated conservatively. If you can't move your shoulder, you can't even get up here, you just can't lift it, then I'm more prone to think this is probably a full thickness tear. We need to get an MRI to confirm. The MRI is the other way that you talked about. An X-ray will not show the soft tissue. X-ray is just showing the bone and the joint, but a MRI is going to show the soft tissue structures. So an MRI is another way to confirm and diagnose a rotator cuff tear, and more specifically the severity of it. So, in other words, is it a full thickness tear or not?
Thank you very much.
No problem. Carol, do you have a question?
Actually, Ron is with me and he has a question.
Sure.
Yes, I just wanted to have you speak briefly about problems with the shoulder and what requires surgery and what doesn't. You mentioned tears and other things that are going on in the shoulder that don't require surgery.
Correct.
Like a tear, does that can that be repaired without surgery?
Yes. So I would say most of the time, probably 60, 70% of the time, rotator cuff tears, specifically tears, right, can be treated conservatively, which means you can just do PT and you can eliminate your pain or get to a point where you're pretty much pain-free and can function normally. On the other hand, there are also people that come in that have a rotator cuff tear and they say, I want to do PT. Or their doctor recommended they do PT. We start to rehab them. They get to a certain point after a few weeks and we say, this isn't getting any better, which means you're going to need, the tear is too great. You're going to have to go get this surgically repaired if you want to have full function back. That just happened to one of my clients. He came in, he did most of the work. He got better. I would say he got 50% better. And then we kind of hit a plateau. And he said, I really don't want surgery. And I said, listen, Dave, I don't want you to have surgery either, but you need it. I mean, there's nothing else that's gonna get this back to full function. He went and got surgery, came back in. We started the rehab after surgery. He's doing great. He got over that hump. So some people do require that surgery, but more often than not, it can usually be treated conservatively. Where PTs do a bad job, in my opinion, of treating things conservatively is you have to give, even if you're doing all the right things. So even if you are a great physical therapist like we have at my clinic, and you're doing all the correct things, the biggest thing that PTs fail at doing, in my opinion, is giving your patients the education and that, listen, even if we do the right things, it's still going to take up to 12 weeks for this thing to get better. That's even if we're doing the right stuff. And a lot of times people, that they're not aware of that. They think after like a month, they're like, I'm seeing no difference. And in which case I reply, listen, you've had shoulder pain for 5 years. We've been doing this for 4 weeks. We're a third of the way through how long this usually takes, according to the research. You got to stick with it. When people have that information, then they understand, okay, this is something that's going to take some time. And then their expectations are adjusted, and they understand where they should be on that healing process. So that is usually where I find other therapists do a poor job, is you have to, one, do the right things, which I won't get into, but two, you have to give people the correct expectation for how long it's going to take and what type of progression is going to happen over that time.
Thank you.
No problem.
Gabe, I have a question.
Sure. Go ahead.
One of your earlier slides talked about people having these problems when they've, incurred a hard labor and having their arms over their head and things like that. Well, at Hershey's Mill, we have a number of people that play racket sports.
Yes.
And what are some of the common issues that you get from continued use of racket sports, pickleball and tennis and paddle, things like that?
Right. That's a great question. So our overhead athletes, typically, if they have shoulder pain, it usually happens because of impingement. Impingement is probably the number one overhead problem that people get. And that is they don't have adequate shoulder mobility, right? So they don't have enough range of motion just to even get up here. Them standing here and reaching, they don't have the correct and adequate range of motion to get up here. So that's just to begin with. Now they don't have the range of motion, and now we put a paddle in their hand and we say, hey, go play a hard game of tennis, right? And now they're coming back and they're trying to get into these planes of motion, and they're really, trying to whack a ball. So now you put a load on a joint that already doesn't have the range of motion to go where you want it to go. That is a perfect recipe for shoulder impingement and for getting pain. That happens all the time. So, and usually once we clear up those mobility issues, whether it be improving the mobility of the joint itself, whether it be performing soft tissue work on these muscles that prevent you from getting up here, like your pec, like your lat, or whether it be strengthening muscles to even get your shoulder blade to move so you can get up here, those things usually take away that pain pretty easily. Another issue that people with overhead athletes have is trouble with their labrum. This is usually more of a baseball pitcher thing or like a professional athlete because of the amount of repetitions they're doing. That's why there's a pitch count. But the labrum is a really interesting structure in that the head of your bicep tendon, right, runs all the way up and becomes a part of your labrum. So what happens with baseball pitchers, they're throwing real hard. And not only they're throwing hard, but they have a ton of range of motion of their shoulders. So when they're cocking back to pitch, they have a ton of external rotation. They're coming back here quick. They're stopping, they're reversing direction, and they're bringing their whole body through to get as much torque and force behind that ball as they can. So repeatedly whipping back here, stopping and coming back around again, that puts a ton of tension on their bicep tendon, which pulls on their labrum. And essentially what it does is it'll create what we call a slap tear, which is it peels the labrum away from the socket, right? It just peels that thing away because of the repetitive motion going on here. So overhead athletes, aside from impingement, if they're throwing or hitting real hard, what ends up happening is they can get a labral tear or a tear in their bicep tendon, which again can be treated conservatively, but those two specifically we see a lot with people that do things overhead. Usually able to treat those fairly well, especially impingement. Almost everybody deals with shoulder impingement at some point in their life. And it's something that PTs are extremely good at treating if you know what to do.
Great, thank you.
No problem.
Hello.
Yeah, go ahead, Bill.
Hey, how you doing, Dave? How about build-up arthritis in the shoulder?
So arthritis in your shoulder, can happen for a number of reasons. When you have arthritic changes to your shoulder, it usually affects your mobility, right? So again, your rotator cuff's job, the reason people get arthritis in their shoulder more than other people, let's just go back to the basics. Why does one person have arthritis and one person doesn't? Your rotator cuff's job is to hold that ball square in the socket. If you don't have strength, or you don't have a strong shoulder, or those rotator cuff muscles are weak, there's going to be more what we call shear force. This is shear force. This. There's always some shear force that happens at every joint. So at every joint, because your body moves, there's going to be some amount of shear force. But if you have excessive shear force, which is more motion, this creates this shear force at the joint, at the level of the joint. You do that for days and weeks and months and years, and this is what's going to create that osteophyte buildup, which is essentially that arthritis. Now, when that gets to a point, we're not going to make the arthritic changes better. So those osteophytes have built up, those bone pieces have built up, and the minerals have built up to a point where now we're not going to be able to change that. That's always going to be there, right? We can improve the stability of the joint. We can strengthen all those muscles and help improve and reduce the shear force, which will reduce your pain, but we're not gonna be able to change the level of arthritis. If you guys watched the national championship game last night, you saw one of Alabama's receivers go down with a knee injury. My guess is after I watched, he probably tore his ACL just from me watching it. But what happened was he was running, he was cutting, and he had a lot of shear force happening to his joint. You could tell that when he planted, there was a lot of this going on at his knee joint. That's how you create tears like in your ACL. That quick shear force change puts all the stress onto those ligaments. And that ultimately comes down to, unless he was hit, he did it just running on his own, right? But that ultimately created that injury. Having strength around the joint, whether it's your knee or your rotator cuff, reduces that shear force. It reduces that chance for injury to the joint, or if you have arthritis, for pain. Now, if your arthritis gets bad enough that we can't improve the pain with it, that's when people elect for joint replacements. So a total hip, a total knee, a total shoulder joint, which is a newer in general in terms of like total joint arthroplasties. The total shoulder is a newer one compared to the knee or hip, but that's when those surgeries are elected. You still have to improve the strength around the joint. Even if you had those surgeries, we still need to get function back in the joint. It's just if the arthritic changes are high enough that we can't do anything about it, and the arthritis is bad enough, then the doctor might elect to replace the joint surface. That's exactly what a total knee or total shoulder does.
All right, thank you.
Kim Morton had a question. Kim, unmute yourself.
Hi, thank you. After PT or with PT, along with it, what are your thoughts about PRP shots for shoulders?
Sure. So it depends on the person. PRP is, or just shoulder injections in general, are one of those things that for some people, it helps tremendously. They go and they get a PRP, which, guys, if you guys don't know what PRP stands for, it stands for platelet-rich plasma. So they're trying to give some nutrition to the surfaces of the joint so that they heal a little bit better. For some people, they get a PRP shot or they get a cortisone shot, and it helps tremendously. For other people, they go and they get that shot and it does absolutely nothing, and they just don't feel a difference. So it's hard to say. There's definitely some benefit to them, and it does help. What you have to understand is that those injections are essentially treating the injury, but not the root cause of it. So if you have arthritis in your joint and you go get a cortisone shot, and we add some lubricant to the joint, and it improves how things moves, things feel better, right? That is a short-term solution, because that pain developed for some reason. And let's say it developed because we don't have enough stability at the joint. We have too much shear force going on. We'll use that example again. That cortisone shot may alleviate that pain for a few weeks, but unless we correct the amount of shear force that's happening, that arthritis is still going to happen, that change is still going to be present, right? So even though those shots do help, we always have to address the underlying cause of a lot of these problems, and most of them are movement related. So
This was rotator cuff, but yes, thank you.
yeah, good question.
Thank you very much.
Good job. Anybody else? Okay. So what do we do if we have shoulder pain, right? It happens a lot. And like Kim alluded to, there's a ton of different options, right? I can get an injection. I can go get a massage. I can go to my doctor. I can get surgery. I can do PT. What's the plan, right? Obviously, I'm a physical therapist, so I treat shoulder pain all the time. But specifically, people that have shoulder joint dysfunction, you need a really solid physical therapist, and I'm lucky to work with some PTs that are very good. The last time I gave this seminar, I gave it to a company called Healthies, and I had someone from Philadelphia who lives in Center City say, "Hey, the doctor. I've had chronic shoulder pain for 2 or 3 years, and they want to do a nerve block and they want to do surgery, and I don't know if I want to do it." And I told her to come out. I'll do a free screen. Thanks for coming to the presentation. Let me see you. And she drove out from Center City, and we did a screen, and she tried PT somewhere else, and she was like, "Nothing's getting better. I think I'm going to do this surgery." She reached out again because she really didn't want it. And I said, "Well, just listen, why don't you just, if you're that concerned about it, why don't you come out and try it with us, you know?" Because I have confidence in our staff, and I was like, I think we're better than most people. So if we can't help you, then for sure, go get that surgery. And she drove out from Center City twice a week for 3 or 4 months, and she is like pain-free. She's like amazed. And so that was over the past 6 months this happened. And that really, I always knew our staff was better for sure. I know we have a really good staff, but that really kind of confirmed for me, man, like we do a good job. But other PTs, unfortunately, sometimes don't do as good a job as they could. So I always look for conservative treatment, especially in PA. If you have a private insurer, we participate in direct access, which means you can go to a PT like you do go to a primary physician. And you can get treated without a physical therapy or without a script, for up to a month before you need to go to your doctor. So that's always a solid way to go. There's no one more qualified to assess your movement dysfunction or to assess movement in general than a PT. The common things that I usually see, just in general, I threw some in here for people that have shoulder pain. And common things that we usually do with most people that have shoulder pain are as follows. One is people that have trouble getting overhead, reaching overhead, getting up here. They usually have restricted length in their pecs, which are these really big, powerful muscles on the front of your chest. They, in a shortened position, they pull your shoulder forward. And we always, with shoulder impingement, with bursitis, with arthritis, people that basically just can't get up here, your pec usually restricts that. And we are always doing soft tissue mobilization and stretching and all kinds of PNF stuff for your pec. So if you guys have shoulder pain and you want to figure out if your pec is tight, just do this. Stand in a doorway, put your arms up to the side, lean forward. If you feel a stretch across your chest, your pec is probably tight. And improving that length helps to improve that shoulder mobility. If you feel a pinching behind your shoulder, we talked about shoulder impingement, you probably have shoulder impingement. So if you're doing this and you feel pain and you don't feel a stretch, you can pretty much be sure that you probably have a little bit of shoulder impingement. And that should be taken care of. Another common thing that we always do, which I talked about a whole bunch today, is improving your thoracic extension mobility. So that middle of your back likes to get stuck in that rounded position, and your shoulder blades rest on that thing. Always, we're usually with shoulder pain or pain with your neck, we're addressing those joints that are around the joint itself. So your thoracic spine, extending over a foam roller like this to help improve how much thoracic extension you have is usually something we're giving to all types of people. And then finally, in terms of rotator cuff strength, like say you don't have pain, but you're like, I want to make my rotator cuff stronger. we're usually addressing these two muscles, your supraspinatus and your infraspinatus, both of which are rotator cuff muscles. Your supraspinatus, we target with a lateral raise with your thumb more pointed toward the ceiling in this position, as opposed to your arm down like this. And we usually have that out to the side. That hits your supraspinatus muscle. Your infraspinatus is an external rotator. So in this image here, this woman is pulling apart a resistance band, keeping her shoulders tucked in at her side. That is a common infraspinatus exercise. So if you ever wanted to just add a little bit of strength for those rotator cuff muscles, just to keep them strong, these two guys are ones that we go to all the time. Okay, so any other questions about any of that stuff, guys, before we wrap up today?
I have a question.
Sure.
I've had a sore shoulder for a few weeks, although today it feels fine. And I take a lot of Pilates and yoga classes where we're doing the high plank. Do you think this causes that?
So the high plank, now I don't know exactly if that's what's causing your pain, but I will say about that position, when you're in a plank position, or you're putting weight through your shoulder joint itself, right? Your rotator cuff muscles are doing a lot of work, right? They're holding the ball in the socket. So that puts a lot of demand on those rotator cuff muscles. If you don't have adequate shoulder stability on top of that, so let's say your scapular muscles aren't as strong as they should be, and those scapulas do something that we call shoulder winging, which means they pick up like this, that puts even more stress on your rotator cuff muscles. That doesn't mean that it's necessarily a bad thing, but there's a ton of demand on your rotator cuff muscles in that position. So if you don't have strength in those shoulder blade muscles and your rotator cuff is doing a ton of the work, it's easy to get trigger point pain in the belly of those rotator cuff muscles. That usually manifests as pain either on the side of your shoulder here, pain in the front, which is pretty common, or sometimes you can get it on more of the back side back here, your infraspinatus of your shoulder. So that could be a reason if you're having trouble with just that position that those are happening. Also, I should mention, guys, we do what I talked about earlier when that woman came out from Center City. We do free orthopedic screens all the time, and I'm actually going to be doing them at Hershey's Mill. So besides the point, if you guys you had shoulder pain and you wanted to come check it out, you can give my clinic a call and you come in for free. We'll find a spot for you. One of our therapists will do a quick assessment for 15 minutes and try and give you some guidance as to what they find. We do that all the time. We've done that forever. They're always free. But I'm going to be coming to Hershey's Mill on Thursday, January the 27th. I'll be there at 9 a.m. and I believe the location might be changing, Sherry, as Sherry told me before the meeting today. But I'm going to be doing screens. I might have one or two therapists there to do exactly that, to come field questions, give you guys a few orthopedic tests, check out some stuff, to see if we can give you some guidance on how you should proceed if you're having any pain, not just in your shoulder. This is for anything, ankle, foot, neck, back, whatever.
And Gabe, talk about how they are to get those appointments, because that's by appointment only.
Yes. So if you guys would like to sign up for that, I would like you to, Sherry, do you want them to send an email to me or should they send it to you or both of us?
They can send it to you. And if they don't remember your email address, they can send it to me either way.
Got it. So guys, I'm going to have you email me. You can email me. I'm going to give you my email. I'm going to put it in the chat box here so you guys have it. But you guys can email me at gabek@kineticptpa.com. You know, we might not have a chat box actually.
We don't, but
Okay.
everybody, it was on the emails that went out about the talk today.
That's
And
correct.
again-
If you guys RSVP'd, you have my email. So
Right. And again, if anyone does not know Gabe or forgot Gabe or can't find Gabe's email, you can just email us and we'll get it right over to him. We'll just forward it straight to him.
Yep. So if any of you guys like to sign up, shoot me an email and we will get you a time slot for that day. There'll be about 15-minute time slots just to accommodate everybody. And we'll probably do those for a few hours starting at 9 a.m. on the 27th.
Can I ask one more question? People in.
Sure. Yeah, of course.
So I've had a shoulder problem for a long time. I went to physical therapy. It seems to kind of go better and get worse. And but my niece is an occupational therapist, and she's getting her PhD, and she
Great.
said that that she's specialized in hands and shoulders, and she said that some of the things that she had learned before.
This is Dana.
Yes, it is Dana. That some of the things that she learned before aren't like as an overall, this is what you do when you're, in graduate school.
Right.
But then when you're specializing in hands and shoulders, she said some of the things were contrary to what she had learned. So I guess I'm just asking, do you guys have somebody who specializes in shoulders and that areas that are really experts? Because do you know what I'm saying?
Sure, yeah. So physical therapists in general receive a little bit of a different training than OTs do, in that occupational therapists, that usually how it works with OTs is when you get into outpatient OT, or if she's in a hospital, right? A lot of times what the hospital system will do is they'll divide, OTs will usually take the hand, or depending on for what issues they have, that they might do, the shoulder, like you said. Now, if she's getting a PhD, that's a little different. She's in a different kind of track, right? But in general, PTs receive in general, when they come out of school, PTs receive a lot more education than OTs do usually on shoulder pain, because it's something that we treat all the time. I mean, every PT is going to be seeing shoulder pain. So just in general, when a PT starts, in terms of starting to treat, like once they graduate, they have a pretty solid knowledge of what's going on with the shoulder. Now, once you start treating, you have to maintain your license, right? And so you start to take continuing education courses, which are more specific once you graduate. So at Westchester specifically, I definitely have taken a lot of shoulder courses in terms of overhead thrower courses for athletes that have pitcher, shoulder, volleyball, stuff like that, pain like that, like I was speaking about earlier. And my physical therapist, Andrew Taylor, has also taken some continuing education, which is more focused specifically on shoulder joint mechanics as well. So Andrew and I are pretty well equipped to treat any type of shoulder dysfunction you guys have.
Okay, so I could ask for one of you for a consult. I'm not going to be here the 27th. But
Yeah, of course. Yep.
Okay.
Oh, for
Okay.
sure. Yeah, definitely ask for Andrew or myself, and we'll try and figure out what's going on.
Thanks.
Great. All right, guys. Well, if you guys have any other questions, feel free to shoot me an email. If anyone would like to schedule a screen, shoot me an email for the 27th. Like Dana had just mentioned, if you guys can't make it that date, or you want to get in before that, give the clinic a call. Our number is 610-430-3545. You can just also type in Kinetic Physical Therapy Westchester in Google, and you'll have our number come up. Or visit us at kineticptpa.com as well. And we'll be able to get you in for a screen. Or if you are actually looking for official rehab, we can get you in for an eval as well. Thank you so much for having me, guys. I really appreciate it. I love talking to you guys. If you guys need any other questions, you need anything, don't feel free to reach out.
Thanks so much, Gabe. We really appreciate you coming.
No problem, guys. Everyone have a great day, and I look forward to seeing you guys soon.
Always interesting.
Awesome. Take care, guys.
Bye, everyone.